Good afternoon, everybody. It is great to be on with our ally and some of the broader healthcare community here today. I hope your May is off to a good start. I want to extend just a special thank you for taking the time to join us in this season. I know a lot of folks on the line work in healthcare policy and advocacy, and for all of us in this world, it is a busy time to say the least. So we really appreciate you taking the time to tune in with us today. Um, if you've been on some of our recent webinars, you know we've been mostly focused on things like advocacy tactics, the new administration in Congress, and how health leaders can make their voices heard in the environment. And of course, that work is critical and ongoing, but the focus of today's webinar is a little bit different. Today, we are really looking at some more core healthcare policy issues, things like outcomes, things like access to care, preventable illness. The discussion today all centers around some really fantastic new research from our friends at Berkeley Research Group, who are here to walk through their new study, what they found, and of course, field questions from our ally community. Before we jump right into that, though, I know we've got a few folks on the call who are new to BMA. So first things first, welcome and thank you for being here. BMA is a national coalition of over 200 health and aging organizations, as well as over 1 million senior advocates. We are focused on all things Medicare Advantage, policy, research, advocacy, and the importance of the program to seniors and people with disabilities across the country. We are an open alliance, and so if this work sounds interesting to you and you'd like to stay in touch, I would love to connect with you. I'll drop my email in the chat in just a moment, and of course, you can also visit us online at bettermedicarealliance.org. So with that, let's talk about today's call, our webinar today. As I said, this is all going to focus and center on some new research from Berkeley Research Group. So we will kick it off with their panel. And we are also very, very privileged to be joined by some of the leading physician health advocates in the country today. So following our presentation from BRG, we will have Mary Beth Donahue, Better Medicare Alliance's president and CEO, facilitating a fireside chat with Dr. Elena Rios of the National Hispanic Health Foundation, as well as Dr. Virginia Caine, the president of the National Medical Association. And they will unpack this work a little bit more, dig into the why of why this matters, and as well as have a little conversation on how we can all advocate for these kinds of outcomes and access issues in our shared work moving forward. Brief housekeeping notes, our Q&A function is open. We also had some great questions submitted from folks during registration, but whether in BRG's presentation or in the fireside chat later, we'd love to hear from you. So please always feel free to pop a question in the chat and we will relay it to our panel. So I think with that, we can go ahead and jump into the session. Caitlin, I will turn it over to you.
Thank you, Jonathan, and good afternoon, everyone. I'm Caitlin Sulridpath, BMA's Vice President of Policy and Research. I'm pleased to welcome and introduce our research partners from BRG, who will be sharing the key findings from their recently released white paper. This paper, which was published last week, provides timely and valuable insights of health outcomes across the Medicare population, with particular focus on minority communities. We're incredibly grateful for BRG's deep expertise as well as collaborative spirit throughout this partnership. Their work has been instrumental in helping us better understand the Medicare and then specifically Medicare Advantage population and opportunities that lie ahead. And we're really looking forward to this discussion today. And so, as Jonathan mentioned, please feel free to submit questions using the Q&A function, and we'll respond as time allows. We'll also drop the link to the full report in the chat here momentarily. And so with that, please join me in welcoming John Barquette, as well as Ruth Tabak from BRG.
Thank you, Caitlin. And let me just say up top, thank you so much, Mary Beth, Caitlin, Jonathan, and BMA for having us on today to talk about the research that we just published last week. As you noted, this research was commissioned by BMA, and it looks at differences between similar populations some of which are in the Medicare fee-for-service program, and some of which are in the Medicare Advantage program. And we looked specifically at different types of preventive care and care that would suggest that proactive care is being taken of a patient population. Could we bring up the first slide? Now, I wanted to just say up top that while I'm going to give a short overview here, my colleague Ruth Tabak, who really led this research, is going to dive into the numbers with you all. But we're going to try to keep this to a civilian level of conversation and not a health policy nerd level of conversation. Trying to bring these data insights that we have here to life for you. That's what we in our policy practice do at BRG. We work with different organizations that want to, one, uncover policy insights, and then two, bring them to bear in policy conversations. And so if you have any questions about this research or other things, feel free to reach out to us after. So we looked at three populations specifically: Black, Hispanic, and Asian American Pacific Islander populations. And again, we looked at them in the MA program and in the Medicare fee-for-service program. And we asked ourselves, if you look at their rates of different types of screenings, say preventive screenings, or their rates of receiving primary care, or their rates of getting potentially avoidable care. That's care that researchers suggest you may not need if you're getting the right types of primary care. And we asked where are Medicare beneficiaries, Medicare fee-for-service beneficiaries, where are Medicare Advantage beneficiaries, and how do they compare? Now you can go 2 slides down, Caitlin. They say when you're learning how to do public speaking, sort of tell them what you're going to tell them, and then tell them, and then tell them what you told them. So I'm going to do the part of it where you tell them what we're going to tell them. And I will start with this on slide 3, ideally. Our main findings here are that Medicare Advantage beneficiaries had higher rates of cardiovascular and breast cancer screenings across the board, and for most of the populations had higher rates of colonoscopies as well. So those were 3 types of preventive screenings that we looked at where we saw Medicare Advantage pretty much overall, those beneficiaries were getting higher rates of screening. When it comes to primary care services across the board, Medicare Advantage was getting higher screenings. And see, can we get to slide 3 there? Is that possible? We're on, I think, 1 right now. 1 more back up.
Yeah, sorry about that. It was coming through differently on my end. There we go.
There we go. Yeah, so I'm just going through the middle column here. And as I noted, higher rates of screenings for almost every combination of the type of screening and the population. Higher rates of primary care across all populations. And then lower rates, right? Because under these potentially avoidable care metrics, you want to look for lower rates. That would be better. Lower rates of hospital readmissions, lower rates of non-emergency ED visits, and lower rates of potentially avoidable hospitalizations for Medicare Advantage beneficiaries in these 3 types of populations. And in particular, in special need plans, those beneficiaries had the highest rates of many of the screening and primary care measures when you compared to fee-for-service among the different types of MA plans. I'll note a couple of caveats. One is that this is the way Ruth will tell you about the methodology, but the type of study that we did it's correlational. We're not proving causation here, but it controls for a darn high number of things. And it is reliable in the sense that it's telling the story of what's happening out there in the marketplace and in the healthcare system. And then second, I note, not every metric showed that there was a imbalance in favor of Medicare Advantage. For example, the rate of potentially avoidable hospitalizations for Asian American Pacific Islanders was slightly higher in MA than it was for fee-for-service. And then, we saw pretty similar rates for Black MA beneficiaries and fee-for-service beneficiaries across things like non-emergent ED visits and preventive colonoscopies. So that's the overview. Overall, it's a story that suggests that MA plans are doing a really good job at getting increasing access to the types of upstream care that prevents downstream care, things like screenings, primary care, and avoiding potentially avoidable care. But now to really dig into it, I'm going to turn it over to Ruth, who will walk you through our study and our findings.
Great. Thanks, John. Nice to be with you all here today. If we could go to the next slide, I'll just give us a couple sentences on our methodology. There's much more detail in the actual paper, which I see Jonathan dropped a link to in the chat. Essentially, through a data use agreement we have with CMS for encounter data for Medicare Advantage plans and claims data for fee-for-service, we were able to start with the entire population of both programs. So all 60 or so million beneficiaries who are eligible for Medicare. We applied some standard limitations, which we document here and in the paper. And then we segmented beneficiaries to the 3 race ethnicity groups that we evaluated, as John mentioned. One note I'll just flag here, and you all in your work may be familiar with this. The kind of gold standard for race ethnicity is often considered to be self-reported data, asking somebody how they identify. Unfortunately, when we're doing research with claims or administrative data, we don't have a self-reported race or ethnicity identity on for every beneficiary for every healthcare service we want to look at. Often what's used instead, and what we did here, is CMS developed variable, usually called the RTI race variable. RTI is a contractor CMS uses to layer an algorithm over this variable with data they collect from Social Security, and assigns every Medicare beneficiary to one of the race ethnicity categories. It is widely used. It is also widely documented that there are some flaws when researchers have compared self-reported race ethnicity to that identified by this variable. There are some mismatches. We included some examples here. We want to be upfront with that caveat to all of this. There is, there has been ongoing work to improve this variable. We hope that continues, and just wanted to note that here. On the next slide, after we had our base populations, as John mentioned, we created comparable groups between MA beneficiaries and fee-for-service beneficiaries. We created those groups based on several variables, for example, chronic conditions or health conditions, whether or not a beneficiary was dually eligible for Medicare and Medicaid, sex, age, length of continuous enrollment, and whether the beneficiary lived in an urban or a rural area. Once we created those matched groups, our population shrunk slightly to make sure that we could really create groups that looked comparable. So in an attempt to control for characteristics that might influence utilization of healthcare services, beside enrollment in MA or remaining in fee-for-service. On slide 6, on the next slide, as John mentioned, we looked at 3 types of services, and we pulled some of the data out of the full paper here that we'll talk about today. We looked at 3 preventive screenings, so health screenings that are recommended for Medicare beneficiaries to receive either annually or every other year. We looked at a series of primary care visits, so either based on the type of physician providing the care or type of practitioner providing the care, or the billing code used that indicates that it's a primary care visit. And we also looked at care that is considered potentially avoidable. And I'll walk through some examples of each of those today where we saw differences between MA and fee-for-service. Here, this slide shows 2 of the screenings we looked at. We looked at 3 breast cancer, cardiovascular, and colonoscopy recommended screenings that are commonly received. Breast cancer screenings are recommended for females between ages 50 and 74. And what we're showing here is that the rate of breast cancer screening among MA beneficiaries is between 4 and 12% higher, depending on the race ethnicity category, relative to their fee-for-service counterparts. For cardiovascular screenings, these are blood tests, other screenings that help to identify risk factors for heart disease and stroke. Similarly, the differences among MA beneficiaries were 5 to 9% higher. For both of these, the biggest difference that we observed was for Hispanic beneficiaries. And then the third one, we looked at colonoscopy screenings, not shown in the bar chart. Again, the biggest difference was for Hispanic MA beneficiaries, 7% higher than fee-for-service. We didn't see a statistically significant difference for Black MA and fee-for-service beneficiaries for colonoscopies specifically. On the next slide, as I mentioned, we looked at several measures of primary care and again found higher utilization rates among MA beneficiaries. The largest difference we found, all the way on the left side of the slide, was the rate of visits provided for Medicare beneficiaries that were coded or billed as annual wellness visits or welcome to Medicare visits. And these are types of visits that are recommended for Medicare beneficiaries to receive each year. And what we see is that MA beneficiaries received these visits at rates between 9 and 21% higher than their fee-for-service counterparts. So fee-for-service beneficiaries who look similar to them on these matching characteristics we talked about. E&M visits, so just kind of regular evaluation and management visits. We also saw higher rates among MA beneficiaries, but the difference was smaller. And then we also looked at the share of primary care visits, so visits provided by primary care practitioners relative to specialists out of total. So what we see in the purple down there is out of all outpatient or office visits that a beneficiary receives, the percentage that are delivered by primary care practitioners. So again, a different but similar measure of primary care. And we see that MA beneficiaries have higher rates, a higher share of their visits were with primary care practitioners relative to fee-for-service. This slide is, again, another measure of primary care use. Here we were specifically looking at primary care visits after Medicare beneficiaries hospitalized. So we looked at two timelines, primary care visits within 7 days of discharge from the hospital and within 30 days of discharge from the hospital. And what we're seeing here is significantly higher rates among MA beneficiaries for visits within 7 days, between 30 and 40%, and still meaningfully higher rates of primary care visits within 30 days of discharge from the hospital, although the difference shrinks slightly. And then the last category of healthcare services we looked at, as we mentioned, is potentially avoidable. So these three measures are readmission to the hospital within 30 days of discharge, potentially avoidable hospitalizations. This is based on a list of conditions developed by CMS that should be treatable in an outpatient setting versus an inpatient hospitalization, and non-emergent ED visits. Again, based on a list of conditions, this time developed by researchers at NYU for conditions that should not need to be treated in the emergency department. These are population level statistics not used at the individual care level, but give us a sense of whether there's care being delivered or activities happening in the home or outpatient setting that help to avoid some of this inpatient or hospital use. I'll just note here, we particularly for the 30-day readmission rate, we saw rates among MA beneficiaries that were nearly half those of fee-for-service beneficiaries. So a significant reduction in MA beneficiaries returning to the hospital within 30 days of a discharge compared to their fee-for-service counterparts. For the other two measures, we saw improvement among Hispanic beneficiaries on both measures, potentially avoidable hospitalizations and non-emergent ED visits. In the other two groups we looked at, Black beneficiaries and Asian American Pacific Islander, the results were mixed, some improvement on one, but not the other. And then last on slide 10, thank you, Caitlin. As John mentioned, we segmented the Medicare Advantage beneficiaries into MA plan types, specifically HMOs, PPOs, and special needs plans. And we compared MA enrollees in each plan type to their own matched fee-for-service counterpart to see if MA plan type might be impactful to our comparison to fee-for-service. The full results are in the paper. We just pulled out a couple data points here that we wanted to highlight, particularly for enrollees, MA enrollees in special needs plans. The preventive screening and primary care utilization compared to their fee-for-service counterparts were really much better than among all MA enrollees. And to us, this was indicative that the SNP model of care requirements, the way that plans are focusing on beneficiaries who enroll in SNP plans and have a high level of care needs, were translating into improved care on these measures, where we really see significant differences compared to fee-for-service, and even more so than we see in other types of MA plans. And then I'll just end with, we have our limitations documented. There's more detail in the slide. As John noted, this paper is shows correlation between these. We aimed to control for several different types of differences between beneficiaries to make our comparison population as close as possible, but naturally there are some variables we can't control for, like decision to enroll in an MA plan or potentially some data quality issues. Although again, we tried to mitigate those with our selection of healthcare services that we used to the extent possible. So we're happy to take any questions, but I will hand it back to Caitlin and Jonathan, and I know we have an exciting rest of the agenda for today.
Thank you, Ruth. We have one question in the chat. I'm just asking if you all have or saw any data in terms of outcomes from the increased rates of visits and or screenings. Sounds like maybe a part 2 project.
We didn't look at, an outcomes measure like, blood pressure control, or, and this may be an interesting topic for later, or, blood sugar control, things like that. It would be a part 2 to, potentially to see if more primary care measures lead to improved clinical outcomes.
Yeah,
Awesome.
no, really appreciate that, Ruth and John, for that presentation. Just one final question for you. Were there any findings that you found either surprising or unexpected as you were moving through this work?
I mean, I'll just start. I think there were some measures where the difference between MA and fee-for-service was bigger than I would have thought. The 30-day readmission measure we just talked about was one of them. That has been a policy focus in quality measures, but I was, I'm still surprised with the degree of difference that we saw. And I think, is an area where MA plans paying attention to hospitalizations and follow-up, there really is a meaningful impact there.
Yeah, I could add on to what Ruth was saying, which is, you might think of, because of the different ways that fee-for-service and Medicare Advantage reimburse providers and plans, that some of these things, some of our results might make intuitive sense because of those incentives. But on the readmissions point, that's something that Ruth and I were helping to write the Affordable Care Act. And one of the things that I worked on when I went into the Obama administration after the passage was standing up the readmissions program that applied to all Medicare providers, especially in fee-for-service. And that's just some color commentary to underscore Ruth's point that that was a more surprising output there.
Yeah. No, certainly a lot of good findings to dig into here. And as we've already heard, maybe some future questions down the road too worth exploring. And so really appreciate you joining us to present those findings. Jonathan, I'll turn it to you for our next segment.
All right. Thank you, Caitlin. And thank you again, John and Ruth. Really appreciate the partnership with BRG on this. All right, so let's keep the conversation going and dig into just some of the why behind this work, the importance of it, and importantly too, how we can communicate and advocate for the importance of these types of issues in our shared advocacy together. So to round out our call, we have just some fantastic guests that I am just so honored and pleased to welcome to the call today. I will do quick introductions for both of them. First, we have Dr. Elena Rios, who is a nationally recognized physician and public health leader. Dr. Rios began her policy career in the early 90s, serving roles in California state government with the White House Healthcare Reform Team and the U.S. Department of Health and Human Services. She is one of the founders of both the National Hispanic Medical Association and the National Hispanic Health Foundation. And in addition to her service on countless boards, including BMA's board, where we are fortunate to have her as our chair, she also launched the Hispanic Physician Leadership Fellowship, which has developed hundreds of Hispanic physician leaders across the public and private sectors. So welcome, Dr. Rios, to the call. And please also join me in welcoming Dr. Virginia Caine to our discussion. Dr. Caine is the Director and Chief Medical Officer of the Marion County Public Health Department and is an Associate Professor of Medicine at the Indiana University School of Medicine. She is the past President of the American Public Health Association and is the current President of the National Medical Association, which is one of BMA's ally organizations. In addition to a very long list of awards, Dr. Caine is also the chair of Indiana University's Clinical and Translational Science Institute External Advisory Board and is a member of multiple infectious disease and editorial boards with the Centers for Disease Control and Prevention. So Dr. Caine, welcome to our call. Thank you to both of you so much for being here with us today. And Mary Beth, I will turn it over to you.
Great. Thank you, Jonathan. And I want to join Jonathan in thanking Dr. Rios and Dr. Caine for being with us this afternoon and just given their positions and the various roles they play in the health and public health community. We know the demands on your time. So we are really grateful for you to be with us and appreciate the opportunity to follow John and Ruth and the great work of BRG. That's the focus of our conversation. I'm going to, in this conversation, pose some questions separately to Dr. Rios and Dr. Caine, and then join at the end in questions for the both of you. So appreciate that opportunity. The research that we just heard from John and Ruth, Dr. Rios, focuses on beneficiaries across various minority populations in Medicare Advantage, and the focus is it's showing that those Medicare Advantage beneficiaries are receiving more screening and primary care and as a result, fewer potentially avoidable services than those in traditional Medicare. And given your experience and what you hear from your membership, what do you see it is about that Medicare Advantage model that enables these stronger outcomes, whether or not it's in care coordination or network design?
Thanks, Mary Beth. Great study, and glad to see the focus on our minority populations. I think it's important to realize the unique differences and assets of our different communities and how we do need to have healthcare programs and services that are more relevant to our communities. And I think this really shows the importance of looking at screenings because we know how much well, let me just put it this way. There's only so many hours in the day. In our communities of color, especially, we learned from COVID, essential workers just don't have time to take care of themselves. So anything that can provide some incentives, and I think it is both the care coordination of MA plans to be able to have a one-stop shop, to be able to go to a place where you know you're going to be referred down the hall or, you know, in the same complex and not have to go to different places as little as possible, making it more convenient for people, less time consuming. I think that's very, very important, and I think this shows the importance of that. Also, the incentives for less out-of-pocket payments. We know Hispanic, Black, you know, Asians, working people have little money to spend on high costs of healthcare. And I think people are a little bit more understanding of the importance of preventive care, especially with the Affordable Care Act making it free, having also MA being a place to have more education because you're getting reinforcement from the different providers that you go to. And so I do think that preventive care services like the screenings that you mentioned are are less costly in Medicare Advantage and very much again an incentive for our people to go and access care more frequently than in the fee for service.
Thank you. And Dr. Rios, just as a follow-up, given again the focus that you give to the broader health system, what lessons do you think the broader health system can take from this?
Well, I think the biggest lesson is that we still need more primary care providers. And I know that what's happening is the physician's time, you know, is being taken up by so many administrative type costs, challenges in healthcare, just the bureaucracies that have developed, the consolidation of healthcare systems for doctors and nurses. We need more allied health. We need more primary care teams. And I think this research and the MA programs show that it works. And I think for the broader healthcare system, you know, there are so many more students in this generation, in the younger generation, going into specialty care. We do need specialists, but I do think that this shows the importance of preventive care to avoid the hospitalizations that are so costly in healthcare.
Thank you. I'd like to turn to Dr. Caine. Again, focusing on some of the findings in the report. One finding that has a bit of attention on it is the potentially avoidable hospital readmission rates among MA beneficiaries are up to 43% lower. And, you know, given this reduction in potentially avoidable care, what do you see driving better preventive engagement in Medicare Advantage?
So I'm going to build on my colleague here, Dr. Rios, in terms of the comments that she was making. And that is, you know, for a lot of our patients, with the traditional Medicare, you don't have a cap on your out-of-pocket expenses, whereas with Medicare Advantage, there's a cap of your out-of-pocket. So, if, you know, how difficult is it? I'm a healthcare professional to go and navigate what my cost is going to be when I'm going to a hospital. I can go, you know, buy a car, I can buy a tire, but when I go to the emergency room or a hospital system, I have no clue what my bill is going to be. So that when you have Medicare Advantage and you know you've got a cap on your out-of-pocket expenses, it makes you way more comfortable making those appointments that you need to make, or even keeping those appointments. I think that's key. I think the other really critical piece is when we look at avoidable hospitalizations, that means one, are you getting a pneumonia when you should have got maybe a pneumococcal vaccine that could have prevented the number one cause of bacterial pneumonia? Or are you coming in again for congestive heart failure because you weren't maybe managed as appropriately as you should? But that requires prescription drugs. And so your Medicare Advantage provides prescription drug coverage, which you don't see with traditional the traditional Medicare program. So I think that you have a lot more screenings, whether it's dental, vision, or hearing, that we see with our Medicare Advantage program. So there's a lot more emphasis on screening and prevention. But the key benefit is the economic benefits that we see both for the system as well as for the patient. But we got to remember, we've got to have the network of providers. Elena's quite right. We have got to have primary care providers out there, especially in our rural communities or areas where it's kind of sparse with provider networks. And so hopefully some of these advantage plans are doing a better job. If they're not, I'm telling you, make sure that you're having a robust number of providers with people of color, because science clearly says patients do better when they're being taken care of someone from their same culture, same social network, and same background. So who's doing better related to that?
Well, thank you, Dr. Caine. And I know we have some of our ally providers on the webinar. So great for them to hear you highlighting that. And also appreciate you recognizing in Medicare Advantage both the economic highlights for the system, as well as what benefits the patient. Was going to shift a bit away from some of the specific findings in the research and just focusing on beneficiaries and how they're choosing. So I'm going to turn to Dr. Rios on this point. When you look broadly at Medicare Advantage, we do see that a majority of beneficiaries from minority populations are choosing MA to meet their healthcare needs. How have you, again, both you and your work and with what you hear from your membership, how have you seen that Medicare Advantage is facilitating quality care and access for minority populations?
Well, I think for the Hispanic population, again, they're very busy and large families and never taking care of themselves, taking care of everybody else. So you see people going into preventive services with higher rates of disease already, or the diabetes that doesn't get taken care of because they didn't know they needed to take their medications every day or check their blood glucose every day for their insulin. There's a lot of misunderstanding, a lot of extra communication that needs to be done in healthcare. And I think the MA plans, I think these results show that there is a lot more communication that is culturally relevant, that is in language, in Spanish, signage, other things that can be done, even the trust of the staffing and having people that are from the community, whether it's in rural America or on the border of Mexico or, wherever you get high levels of certain groups of people, and having trusted staffing and trusted outcome results, feel better kind of thing. And I think that's what this shows. So for quality care, it's very important. We all know that value-based care is about the outcomes and the impact, not so much numbers. And, you want to see the trend go in the right direction for whatever the disease metrics are. And I think the other thing that's important is to realize that with coordinated care, you have more emphasis on the data and the metrics and the collection of the data, because you need to pass on the electronic medical record information from one doctor to the other, or from one team member to the other. The diabetic educator, for example, needs to understand how to explain the diets to the patients, if the patient needs more diet control, etc., or the medication, the pharmacist. And I think that people don't or underestimate the importance of coordinated care and also team care. So, and I guess the only other thing I'd say is that there's just so much to learn from our communities, and listening to the patients is very important. And again, because you have a more of a closed system, you tend to want to understand what are the problems of your patients so that you can help them more than just a one-off visit, to a clinic or a medical practice.
Thank you. And appreciate you zeroing on value-based care, because I do want to turn to Dr. Caine regarding value-based care as well, because in the study, it does highlight some of the benefits of accountable value-based care. And it's just important to be able to see how that is important for beneficiaries. And more broadly, we do see for information coming out of CMS that they aim to have 100% of beneficiaries in accountable care arrangements by 2030. That's what we know as of now. And so, Dr. Caine, what do you see as the importance of value-based care? And what should healthcare leaders, those you work with, and again in your membership, Dr. Caine, they should be aware of?
This is value-based care is the direction that we really need to go, because it's based on results in terms of the success of patient outcomes. The traditional fee-for-service is I get paid for every person that I see, but I may not necessarily really move the dime in terms of improving health outcomes significantly. Whereas with value-based care, you're paid based on results of improvement related to health outcomes, such to the point that you're going to find more healthcare systems actually providing more social determinants of health services in order to reach that goal. So we do just a traditional medical model of how we see patients. They come to our doctor's office, we give them education and whatever, write a prescription for medications. We may provide education for nutrition or something of that nature. But with social determinants of health, which we're seeing more and more people who are involved in the value care. I practice out of the fifth largest public health hospital in the country. That's Ashkenazi Health. We have gone to having more of a focus on addressing social determinants of health. We want to make sure that transportation is there for our patients. Safe housing if they're homeless. Providing that cultural competency in terms of understanding what their culture is if I'm trying to educate them about nutrition and lifestyles. And unless you add that component to what you do for traditional medical care, I think it's going to take us much longer, years, to really push the dime unless we're really focusing on value-based care, which is paying based on results, not how many people you touch, but it's based on improving health outcomes for a certain population that you are responsible for.
Thank you. Thank you. Jonathan, do I have time for a couple more questions still?
Yes, you do.
Okay, great. I just want to make sure I'm following the rules here. This question's for the both of you, Dr. Rios and Dr. Caine. And this relates to, again, the work that we do with the allies who are on this webinar now in our advocacy for the protection of MA for the seniors in the program. And many of our allies here do both work in policy, advocacy, research. And given the work that you do, how do you think healthcare leaders can raise awareness of the importance of their work on minority health issues more broadly, especially in the current advocacy environment?
Well, I think trust is really important, and we need to trust the healthcare system. We need to advocate for benefits, such as the benefits that we talked about under Medicare Advantage, preventive services, and more education for people to understand why they need to come back to see the doctor, being compliant and adherence to their treatment regimen, especially with chronic disease patients in our communities. So I think having more focus on outreach to community-based organizations and the clinics and hospital relationships, medical practices, having community health workers, or having trusted voices in the community that are increasing the education even outside of the healthcare system. Just how important it is to go to coordinated care sites and MA plans, I think is important. The other thing is, given the decrease in research, I'll just say preventive services research, the whole Department of Health and Human Services is being decreased, which means there's going to be a lot less staff involved in giving support for community education. And I think that that's a big mistake, because we're talking about a program that has shown that coordinated care and education is important. And so the direction that the administration is taking right now to decrease staffing and to decrease our programs that are related to the social determinants that Dr. Caine was talking about, but also just determining our community involvement and participation in healthcare training and education. And I'll just say one more word about training. I think it is important that the universities that are also getting cut because of research, what is it, the indirect cost rates of research, for example. One big change like that has closed down numbers of students that are going to be admitted to medical schools and nursing schools and dental schools. So we're going to go backwards in terms of the workforce needed for the coordinated care and the importance of having more, more staffing. I shouldn't say staffing, more professionals, more health professionals getting involved with educating their policymakers and educating their directors of hospitals and medical societies about the importance of the programs that our community needs. Our communities have special needs that are going to be decreased because of all the changes that are happening right now with this administration's attempt to weed out fraud and abuse is one thing, but to actually cut down on the benefits and cut down on the numbers of people that are able to access MA plans, especially. This is what, we're really talking about, an important part of healthcare that shows how relevant it is to our communities. We need to support Medicare Advantage and support Medicaid and support other government programs that help our communities get increased access to care.
Do you want me to answer that one too?
Yes, please. I mean, I know
I'm happy to do that. So let me just say here, we have what we call sort of like a sick system. What do I mean by sick system? 88% of our medical expenditures are on chronic disease conditions, but are also on acute, more medical care. So if I'm coming into that hospital and I have pneumonia, and I may have some underlying conditions, I may end up in the intensive care unit on a ventilator. Versus if I had just been vaccinated, okay, I have maybe a 95 or 99% chance of preventing a hospital admission compared to it's $1,000 a day staying in the hospital. So based on the cost of one immunization just for like pneumococcal vaccine preventing pneumonia, I have saved tons of money, but I've also saved maybe morbidity and mortality. But let's also talk about the fact we got to understand we don't all live in large urban metropolitan areas where we may have tons of hospitals. You know, we have a lot of hospitals in the rural communities, and people may have to go and drive an hour or an hour and a half away. So we've got to look at what we allow expenses for. Like for traditional Medicare, you know, they don't always say it's okay to have a routine blood test. Like for this is giving cholesterol. You know, heart disease is the number one killer in this country. High cholesterol contributes to that. Now, task force says that you need to get a cholesterol blood test every 5 years. But if I was just coming for my annual visit and I wanted to have some blood tests, that's not covered.
Mhm.
And so I think we've got to really relook at what we're providing coverage from, that's from a prevention standpoint. I think we need to have these strategies like we used to have, very successful in getting more primary care providers in areas where there's a physician shortage. Hey, what about those forgiveness loans? You can be trained with a forgiveness loan as long as you can serve in this area for 3 to 5 years. But it's in a location where it may be hard to attract primary care physicians. And listen, don't you doubt it. Primary care physicians work themselves to the bone. I'm a specialist as an infectious disease physician, but the reimbursement rates for primary care physicians are not equal to their specialists. So it's more harder to attract people. I'm going to be working my muscles to the bone, working hard Monday through Friday. I heard about this physician in Baltimore. I'll be quick. You know, he had cancer, kidney cancer, and he was just providing services to his clients who didn't have the money or the access. And so, whatever we can do with our systems, we've got to broaden our social networks to make it easy for people to want to go and see these providers in our Medicare Advantage programs. We got to make it cost effective. And misinformation can have such devastating damage to our patients that we've got to have a good campaign on community education to help with our patients. So 15 minutes I may have only to see my patient. Wow. It's hard for me to write my note, order my labs, and then I got to teach them about nutrition. Whoa. We don't pay our physicians for prevention screenings, a lot of them. If I'm talking to you about stop smoking, the number one cause of heart disease, I should be reimbursed for that. So we really need to look at doing more financial reimbursements for more emphasis on prevention.
Thank you. And really appreciate Dr. Rios and Dr. Caine sharing your perspectives on what's needed, for physicians, for providers, the focus on primary care, and just as we look at what's needed for Medicare Advantage beneficiaries, what we need to protect and what you see as a value. Before we close, would love to be able to give you the opportunity to just with those with our ally community, and as we obviously going to be sharing this webinar externally, just to speak to your organizations and how allies and partners can connect with you all to be part of efforts to achieve the missions of your organizations and the physicians who you're advocating on behalf of?
So I'd
Well,
like, yeah, go,
I'll just
go,
say,
Elena, go on.
yeah, just say the National Hispanic Health Foundation's new mission. I went full time with the National Hispanic Health Foundation last summer, and our new mission is to transform the healthcare system through leadership, research, and education. And one of the things that we've decided to do, besides the leadership training of physicians, to continue that, we've been doing that for years, and giving scholarships to the next generation so that they can have an incentive to continue, especially those students who want to care for our underserved communities. We have a strong interest in collaboration across the National Hispanic Health Professional Associations. There are groups for doctors, nurses, pharmacists, dentists, public health, PAs, dietitians, social workers, mental health workers, and probably others that we don't know about yet. I think the Latino Surgical Society got started a few years back. We would like to have them work together in advocacy, especially for issues that do increase access to our patients, and like this research shows. And we do want to see more continued focus on the issues involved and the gaps involved in health equity, whether it's, Black, Brown, Native American, Asian, um, women's health, LGBT health, whatever. We're very concerned that we need to have our voices strengthened by collaboration, and we're bringing the groups together. We've actually worked together for over 20 years on our scholarship program, but multidisciplinary, and the group is now called the Hispanic Health Professionals Network. And I think that that's a major step forward for us, given the context of decreasing DEI and making everybody the same. We're all here for all Americans, but we need to showcase that we are not just all, gang members or, bad people. And we're very concerned about the quality of our image and our advocacy voice.
Thank
Well,
you,
the
Dr. Rios.
Yeah.
Well, the National Medical Association is the collective voice of African American physicians or Black physicians. We try to be the leading force for parity and social justice in medicine. We feel we want to have a positive impact on the elimination of the health disparities. Part of that involves, when we're looking at these different plans, is what can we do from a leadership standpoint of collaborating with these very organizations we need to impact to make sure that they're providing a positive experience for their enrollees. The majority of our enrollees, have a great experience with their Medicare Advantage, but we do have some other criticisms sometimes that may occur, and how can we address that? So things such as maybe denial of medical claims that may occur repeatedly in some instances that can delay the quality of care. Wouldn't it be wonderful if we have some kind of partnership with our healthcare professionals along with our insurers, coming to some shared decision making in terms of, what kind of benefits would really enhance our healthcare system? And I think because we're going to have less resources available, less technical assistance, we're going to have to depend on collaborating with each other. Alina and I, both our organizations, have done outreach and communications to hospital systems, patients. We got to do more, but I think we got to extend more of a working relationship with our insurers in terms of policies. And then how does artificial intelligence, what are those tools? those algorithms that may be built in terms of how we provide healthcare services. I think we're going to have to look at some new technological advances that may make us more efficient and may save us time, but making sure that we don't have any biases built in some of these algorithms in terms of how decision making is being made in terms of healthcare. So we've just got so many fronts that we have to do. And I think these organizations and the research that was done by this report is really critical for us to provide an assessment of where we are, how we can always continuously be a healthcare system of excellence and build on of what we know. And I think we've got a good start with this relationship and continue to have collaborations among all of us. But wow, we've got to educate the public about the importance of this. And with so many plans, it's kind of complicated. I don't know what all the benefits are. When we can work on trying to simplify that for the average person to understand what they're receiving as a plan or a benefit, I think we're going to knock it out of the park. Thank you.
Well, thank you, Dr. Caine and Dr. Rios, and really appreciate your visions and also your very practical solutions with a tone of optimism, because we know it's a challenging advocacy environment right now. And whatever partnering and resource BMA can be as you prioritize the need, as you were just saying, Dr. Caine, about the need for education and also just the importance of your membership and your physicians on the front lines, understanding the complexities that seniors are facing. And you, like you just said, Dr. Caine, and you've referenced Dr. Rios, it is such a complex environment with the health systems and the providers and the plans, and whatever we can be doing to partner with you, and appreciate you recognizing the value of this BRG research to help us in the assessment of where the needs are met or not being met for minority populations, and what we need to be doing to be helping address their challenges and just making the whole beneficiary experience less complex. So thank you very, very much. Turn to you, Jonathan.
All right. Thank you. Thank you again, Dr. Rios, Dr. Caine, and also John and Ruth for joining us today. We are a few minutes over time, so we will let everyone go. Parting note, there's a lot moving on Capitol Hill. Budget reconciliation, there's changes in CMS, the administration. We will do our best to keep you apprised on everything you need to know in the weeks ahead, especially as it pertains to Medicare Advantage and the aging ecosystem. So we will probably do another one of these soon to bring you some more insights. And in the meantime, please, please, please always reach out to BMA if we can be a resource to your work and to connect on anything. So thank you, everybody, and take care.